session. Every Saturday, we have 2 hours of CMEs, and we have been doing excellently every month so far. And Dr. Arthi Chakravarti, he's the CME chair for this year, and he's a urologist from Alabama State. And we have an excellent, outstanding moderator, Sagar Galvankar. He is an emergency medicine physician in Florida State, and a highly academic person, and he is very instrumental bringing us excellent speakers all this year. And I thank Chicago Medical Society, who does the CMEs for AAPI organization. And we have a beautiful convention coming up in June in San Antonio, which is June 23rd to 26th, and we are looking for our members to come and join. We have about 25 CME speakers who would touch base with all the topics. We have wellness CMEs with lifestyle medicine specialists giving us talks. So a bunch of CMEs, and we have a lot of other activities as well during the convention. It's a 3-day convention in San Antonio. With this, I'll stop here, and I will hand over to Dr. Arthi Chakravarti, and he's going to introduce the speakers and moderators of the session today. Thank you all so much for coming.
Thank you so much, Anupama. And like I just now said before,
Go ahead.
You coming to us between your break in the OR just underscores the point that we are all busy physicians and take time out to do this excellent work and also CME talks. And I'm very, very proud to say that this perhaps is our last or second last CME. We may be doing one in June 11th. That's the second Saturday of each month. We've been trying to do it on second Saturday of each month, starting at 12 noon Central Time. And we have had, this year, I asked Anupama that let's do something outside the box rather than doing a specialty specific. We tried to do all our talks absolutely, which will be enjoyed by all specialties. And we've achieved that. We've had excellent talks, and the talks are also on our AAPI website, and you can always go and search for it there. Today we have got 2 excellent speakers, but most importantly, before I introduce them, I want to thank my partner in crime, so to speak, Sagar. He has been so helpful because he's extremely academic-oriented person, has plenty of laurels, which I'm going to just briefly introduce to you. People know him, but his laurels are like he's a founding director for research and core facility at the Florida State University Emergency Medicine Residency Program at the Sarasota Memorial Hospital in Florida. He graduated from Pune University, residency trained, board certified in internal medicine and emergency medicine, US and India. He trained in South Florida, holds a double master's in public health and business management, prestigious fellowships of Royal College of Physicians of UK, American College of Academic International Medicine, and you name it. He's got so many fellowship and specialty organization membership. His 2 decades of work is decorated by publications, citations, and lectures around the world, including the prestigious Kazi International Leadership Award of 2022. He's a AAPI Distinguished Award winner twice, once as a resident and once as a young physician. So I could not I could not get a better CA partner, co-chair than Sagar. He has been very instrumental in thinking about these talks, thinking about these topics, outside the box topics, and also being very, instrumental in bringing excellent speakers. So without further ado, we'll have this, we have 2 excellent speakers, and I'm going to introduce them one by one. Our first speaker is Arthi Bhaskaran, who is currently the medical director of Vitas Healthcare in Fort Worth. Her presentation today would be very interesting: broken crayons, still color. And she's going to be talking about her life-limiting illnesses. And I'm not going to cover her talk description, but Arthi is very well known, and I actually her resume is a very long resume. So what I'm going to do is I'm going to actually post this, but if I can do a brief bio of that. It's a huge resume, but she did a medical school in India, then moved to England, where she completed her surgical training. In 2005, Dr. Bhaskaran moved to USA, did emergency medicine residency at UT Southwestern and fellowship in hospice and palliative medicine from UT Health San Antonio, where our next convention is going to be and where our president is from. She is passionate about educating healthcare providers and community about end-of-life care. To her, hospice care is about providing patients with life-limiting illnesses the autonomy to choose their care by meeting them where they are. It's about relieving suffering, improving the quality of life, and giving them their dignity back. So, Arthi, the stage is yours.
Thank you. Yeah. Hi, everybody. Thank you for being here today. I know Saturday is usually a day where you spend with your family. So I'm honored that you've taken the time to be here to hear this talk today. So like Dr. Amit said, most of my career has been based out of surgery and emergency medicine. And while I was doing emergency medicine, I was worried that we were doing too much for some patients and that we weren't giving them the choice to decide what they wanted for their end of life care. And so I went off to do a fellowship in hospice and palliative medicine. And so today I'm going to give you like a brief overview of what hospice and palliative medicine is about. And if you guys are okay, can I start?
Please do.
Yeah, thank you. So when I say broken crayon still color, it just goes to imply that just because you're at the end of life or just because you have too many medical problems doesn't mean that you could still have a good quality of life. I have no disclosures. So today my talk is pretty much going to cover some of the statistics, like, you know, what does end of life care look like in the US, and, you know, some data that I got from studies, and what are some barriers that we face when presenting, and, you know, more like it's not just end of life care, it's about people with serious life limiting illnesses. What are some options that they have, and how can we help them have a better life? And then the impact of hospice and palliative care. We're going to talk about the difference between hospice and palliative care. We're going to talk a little bit about when is the right time to discuss these options. And I'm going to end the talk just with a brief overview of hospice care. So talking about statistics, previously the average life expectancy was 50 years or less, as you can see. But currently the life expectancy is 78.8 years, right? So people are living longer, and when they live longer, you know, usually people retire at 65. And so that was a good age, but now from 65 to 78, people are living, they don't have much income, they don't have many options, their health is declining, and they're not really sure how they can go about having a good quality of life. So in 2020, the US spending in healthcare grew by 9.7%, right? That was 12,500 extra per person. And that's a lot of money for somebody who's, you know, retired. People over 65, in 2019, they made up about 16% of the population, as you can see from the top graph here. That was 54.1 million. And this is a 36% increase since 2009, while the under 65 age population only increased by 3%. In 2040, we expect the over 65% age group people to comprise 21.6% of the population. And if you look at the second table down here, you can see that people who are over the age of 55 actually account for over 50% of total healthcare spending. So currently, what does it look like, right? So when we talk to people about their life choices or the health choices that they want when it comes to their healthcare, A lot of people say that they don't know. Some of them say, hey, you're the doc, you should be able to tell me what I need to do, right? And when they looked at statistics, they found that half the people believed that they had too little control over their medical decision making, right? And those numbers were higher in people who had poorer health. And that's on the first, top left corner. If you can see, 49% of the people thought they had too little control over their health, right? And the one right below that said 7 in 10 Americans, that's 70% of Americans would prefer to die at home, but only 40%, which is the second column below that, felt that they would actually die at home, right? And then they went on to, further dissect this out to find out what was truly important to people when their health was declining, right? So 54% of the people felt that it was more important not to burden their families financially by their care. And only 23% thought that they wanted to live as long as possible. So for them, for most people, that is fairly true, right? You don't want to be a burden for your family. You don't want to leave them with healthcare costs. And so while the families want you to live as long as possible, that's not what patients want. And then when you look at the bottom right corner, you see that only 1 in 10 people actually report discussing their end of life choices with healthcare providers. And that is, just not here. It's traditionally all over. I went to Taiwan to present at an international conference on end of life choices. And many people on the eastern side actually approached me and told me that they've never discussed this with with patients. All they say is, hey, these are your options. What do you want? Has terms of, do you want treatment or not? But beyond that, nobody else pushes that to discuss what's truly important for patients. And when we go down here, so what are some barriers that we face, right? And why is it that people are not having these conversations? I think the number one problem of this is, as physicians, we're really poor prognosticators. We're not really sure what's going to happen to patients. And so we don't even cross that boundary to discuss this, right? And second is death is unpredictable. There's lack of understanding between what palliative care offers and what hospice care offers. And there's barriers to goals of care conversation. When I say that, I think as far as all of us go, we all know that we're all under time constraints, right? We're given 10 minutes, 15 minutes per patient, and it's hard to have these conversations when these conversations take much longer. And we are hoping that the next provider, the next person meeting the patient would have this conversation, and that doesn't often happen. There's limited education on end of life care. And there's always some stigma related to that because people believe that once you give up treatment, that you're going to die and there are no further options for them. If you look at this graph on the side, I really like this graph because it talks about, this is the most common thing that we see, heart and lung disease. If you look at the 50% mark where their functionality, where they mostly now come down to sitting and standing, up to the point that they reach that mark, the decline is pretty slow. But once they reach that stage in their life where they're not really functional, they can't do much work and they can't take care of themselves, their decline is pretty rapid. And that's why when we look at what we call the PPS score, the scores, we look at what is their functional capabilities, how much can they do, how much can they participate in their own life, are they able to make their own decisions, can they cook, can they walk, can they do can they do some hobbies, can they participate in in like functions happening around their home, can they actually do what is important to them. And when they come back and they say they're not able to do some of those things, that's when we know that they've reached the point where they're going to decline a lot more rapidly. And finally, it's also that people believe that if they have to enroll in hospice, they have to have a do not resuscitate order. So this is, I think, one of my favorite slides, right? The surprise questions. And I think we use that a lot more in hospice and palliative than we do in any other specialty. And I think the question goes is, would you be surprised if the patient in front of you died within the next year? And most often, I think all of us recognize that we go into a patient's room, we see a patient, and we think, oh my God, this patient is not doing well and may not live much longer. And so, they did a systematic review and meta-analysis of this, where they went through 26 different papers, and they included papers that had that if the patients or if the physicians were asked these questions, and if they were written in English, then they included the papers. And they assessed the accuracy of this surprise question by time scale as to when this question was asked during the disease course, and which clinician asked that question, and which specialty did they belong to. And what they realized is that doctors were more accurate than nurses at recognizing people in their last year of life. And the pooled accuracy was almost 75%. So if you ask that question and you say, hey, would I be surprised if this patient died in the next year and the answer to that, if you say no, you're more than likely going to be right about that. And they also said that the oncologists were better at predicting this. And if the time frame for that surprise question was decreased to 6 months, so instead of saying, hey, would you be surprised if this patient died in the next year? And you changed it to say, would you be surprised if this patient died in the next 6 months? The accuracy went up. And that accuracy continued to climb if the time frame was reduced to imminent death, so 7 days or 30 days, or even this admission. So I just wanted to briefly touch about what is the big difference between hospice and palliative care, right? So both of them have a lot of things in common, where it's all about symptom management, decreasing the stress of the illness, and providing physical and psychological relief to patients and their families. But I would like to say there's a big difference in that the palliative care services can be started pretty early in the course of an illness. So it can be started at any stage of the illness, like the day the patient is diagnosed, or any time during the course of the illness, and it's usually paid by insurance or self. While hospice care is paid or completely covered by Medicare, Medicaid, or private insurance, it's for people who have a prognosis of 6 months or less. And it's after they've gone through all the curative treatments and when they don't have any more treatment options left for them. So just going a little bit more in depth in this. So palliative care is specialized care for patients with serious illness. So when you ask what is serious illness, right? It could be somebody who's had cancer. It can be somebody who has a stroke. It can be people who have MS. It could be a wide variety of things, right? And the goal is to improve the quality of life for the patients and their families. They focus on managing their symptoms. And so, for example, the oncologist will come and say, okay, I'm going to provide chemotherapy for this patient. But once they have chemotherapy, they may have nausea, vomiting, hair loss, they're stressed, they're weak. They have many other symptoms that follow that. And palliative care can help with that, right? The focus, so like I said, the focus is managing their symptoms. So any age, so patients can enroll at any age. So we see pediatric patients, we see infants with congenital disorders to all the way to the very end of life, right? So any age and at any stage of the illness. It can be provided alongside with curative treatment. So we also help with coordinating care across different providers and different specialties, right? So we can become your go-to point for communicating between the primary care providers and the specialists, or within the hospital setting with, we can be the link between the different specialties, right? And the quality, and so they actually said that by providing palliative care, it improves quality of life and decreases symptom burden by 66%. And it also drives up satisfaction rate by 93%. And they did a study to say what is the most or the strongest predictor to decrease readmissions. And they said the quality of communication is the strongest independent predictor for readmissions, right? So if you educate, or we as physicians educate our patients, and we're able to talk about their options and goals, during that admission, it may prevent readmissions and more than likely prevent readmissions. we also help match, the patient's goals and wishes to what they want with their care. So if supposing a patient comes and says, hey, I want to try only one more chemo session, and then I want to stop if it's not working, then we can help communicate that with the oncologist and help the patients achieve that goal, right? And we also help match what the patients and family need with what resources are available. Palliative care decreases ER visits and ICU utilization. And I'm going to talk more about that in the next slide. And it improves hospital quality measures. So what is the impact of palliative care? And so what it says is, this is from the Center of Advanced Palliative Care. And this is a really useful website for people who want to go and learn a little bit more about palliative care. So it decreases hospital readmissions by 48%. That's a 28% reduction in cost for the patient per day for inpatient settings. In the outpatient settings, it decreases hospital admissions by 50% and decreases ER visits by 35%. For skilled nursing facilities, if you have them already enrolled in palliative care, it actually decreases hospital or ED transfers by 43%. So for patients who are home-based, like they stay at home and they're taking care of themselves, it decreases healthcare costs by 36%. I know there's a lot of emphasis on like ACOs and healthcare plans about decreasing hospital readmissions and, and all those various things. So for all the people enrolled in that, it decreases the cost by $12,000 per person that's enrolled in that system. And for hospital-based palliative care, it improves the patient and family satisfaction rate. And I don't know about you guys, but I know in the ER, there's a huge emphasis on Press-Ganey and patient satisfaction scores. And, a lot of people don't realize, but even in the ER, you can refer the patient to palliative care right from the ER. They don't need to be admitted to the hospital to get onto the palliative care services. And it decreases 30-day hospital readmission rates. And the cost saving per patient for each inpatient care is 9 to 25%. Like the slide says, we cannot change the outcome, but we can affect the journey. So we're going to, I'm going to come back to the slide, but I wanted to also talk a little bit about when it's a good time to have these conversations. So if you look at this scale, this is the outpatient setting, the clinical setting, and then it's ER inpatient, and then the final stage of the disease. So the top arrow here, which says that this is when a patient is diagnosed with serious illness, right? And when they're diagnosed with it, the amount of disease modifying treatment is actually a lot when they first get diagnosed. And so, but as time progresses, their options for curative treatment actually decreases. So if you initiate palliative care conversations pretty early in the conversation, it actually helps, because by the time the patient runs out of options, the palliative care team is fully involved with the patients. They've actually discussed goals of care with the patients. They know what the patients want and actually can help improve outcomes. But more often, it's when they reach this crisis point, that's when we're having the conversation. And if you see that that's actually not very beneficial for the patient, and it's too late to be having these conversations, because one, you don't have a rapport with the patients, and patients don't trust their physicians at that point, and they're very dissatisfied with their care. So what is the impact of hospice care? I think this is something that I just want to touch a little bit upon, right? So a lot of people believe that hospice care equals just giving up on life, right? That they don't have any more options, that they don't, that they're just going to go and die. So they did a study to see what or how does hospice care impact patients. Right here, if you look at it, Trella Health is, a separate company, an independent company that provides healthcare data analytics. And they took into account all the patients who died between July 2018 to June 2019, which was a total of 904,000 patients. And they actually timed the impact. What was the impact and timing of hospice admission on end-of-life care and healthcare costs, right? So they included patients who were hospitalized at least once in the last 12 months of their life. And just bringing you down to the slide on the bottom right, you can see that 7% were enrolled with early hospice, which is 3 months or more of care that they had got. So patients, like 47% did not get any hospice care. 29% of the patients were enrolled really late in hospice, which is the last 2 weeks of care. 17% were admitted to hospice between like 2 weeks and the last 3 months of their life. And only 7% were admitted to hospice when they had more than 3 months to live. And why is that important, right? So they dug a little further into this, and they found that patients who were not enrolled in hospice were 10 times more likely to be admitted to the hospital in the last 1 month of life. And this goes back to one of the earlier slides that I showed, which said that patients really don't want to be spending that last, weeks in the hospital. They rather spend their time at home with their loved ones. And the other aspect of this is their healthcare cost was 27,000 more than, more healthcare costs in the last 3 months. And that's a lot of financial burdens on patients, on families. And that also goes back to my slide where I'm going to just go back to show you that slide again, where it said it was more important for them not burdening their, families financially. And it was less important to them that they live as long as they, the families wanted them to live, right? And some of the other things, they're also important, like if you see in this graph, is having their loved ones around them, being at peace spiritually, making sure that the family is not burdened with tough decisions about your care, and being as comfortable as possible without pain. All of those things were really important to patients. And I know, just thinking about this and having parents-in-law who are much older now, they feel the same way, because we've had a lot of conversations with them and asked what's important to them. And the number one thing they all say is, we don't want to be a burden on you guys, right? And I think as Indians, we can all relate to that because our parents tell us the same thing. And here, also going back to this slide, although it says Americans, I would like to extrapolate this to even apply it to our Indian communities. But they said, if you had a choice, where would you prefer to die? And most of them want to die at home. And I think a lot of you on this call would also agree with me that that is where we see ourselves. Even in India, most parents would prefer to be at home with their kids and grandkids around them. So also coming back here to this slide, I want to just say that when there is a late hospice referral, there are 5 times more likely to visit the ER in the last month of life. When I worked in the ER, and I can say that this is true because when I worked in the ER, I had many people who came to the ER who just did not want to be there, but they were there because either the nursing home sent them or the families didn't know what to do and they brought them over to the hospital. I had a patient that came into the hospital, almost every month with end-stage heart failure. And the last time I saw this patient, they were in the ER and they were already on a dobutamine drip. And I sat down with them and I said, what's going on and how can I help, right? The patient then told me, I just don't want to be here. I know that they want to hold on to me, but I just want to go home. And I don't want to keep coming back to the hospital. Each time I come, I spend weeks in the hospital and I'm not happy here. They poke me, they prod me, and that's not what I want. And when I asked her if she had ever communicated that with anybody, she said no, because nobody had asked her about what she wanted. And she said that physicians would come in and speak to her and say, oh yeah, your heart isn't functioning, let's do this and let's do that, and we can change your medications or modify it or even tweak it a little bit and see how you do. And she said she really did not want that. So I would say that it's a really good thing to just ask the patient sometimes, you know, like, what is it that you want and how do you see your health? And Dr. Veeder, who's going to present after me, is actually going to discuss, you know, how to have those conversations and also discuss, you know, how do you discuss what's important with the patient and advanced care planning. So coming back to this slide, right? The one thing that we also miss is initial stages of disease. That's when the patient can best communicate with us, right? As they get, you know, as their illness progresses, they get weaker, they can have more fatigue, and some of them are not able to communicate their thoughts. They don't have the capacity to tell us what they want. And so it's really important to start these conversations pretty early during the course of the illness. So I want to also talk a little bit about hospice philosophy, right? It was actually started by, or Dr. Cicely Saunders is actually considered to be like the founder of hospice. So where does hospice come from? It was a word which was coined initially that during pilgrimages, when people used to take long journeys, this used to be a place of rest. So people used to stop for rest, like overnight rest, but they were too ill from their journey that they stayed there much longer. So it was initially started as just as a shelter or haven for a weary traveler. And that grew, and that concept grew, and then that became what we know as modern hospice now, right? So hospice's philosophy is more about providing specialized and compassionate care for those with advanced or life-limiting illnesses. We affirm life and accept death as the final stage of life. So it normalizes death. So it's not an extraordinary event because everyone eventually dies. So you normalize the final stage of death or final chapter of life and provide them with the best quality of life that they can have. It does not hasten, nor does it postpone death. And it honors the patient's wishes and goals and focuses on the patient and their family's quality of life. So who is eligible for hospice, right? So when we talk about eligibility, like I said, we look at their performance scale, and when they reach about 50%, we need to start thinking about whether they're eligible for hospice or not. And most people feel that it is set in stone that the patient has to die in 6 months and have less than 6 months to live, and that's when they can be referred to hospice. But that's not really true, because what it says is that people who have a life expectancy or more than likely have a life expectancy of 6 months or less if the terminal illness runs its course, right? And 2 or more physicians have to agree that the patient is hospice eligible and the patient or their family consent to hospice. Just because they're eligible doesn't mean that they are going to agree to hospice services, right? So what are some things that we look at when we decide if patient is hospice eligible or not, right? We look at their symptom burden. We look at what is their decline like, what is their healthcare utilization, and what comorbid conditions do they have, right? CMS has set up several guidelines, and which is system-based, like liver disease or cardiac disease. But this is like a general guideline that we all use more often. And so the symptom burden is, do they have a lot of pain, which is not being controlled currently? Do they have nausea, vomiting, dyspnea? Do they have an intractable cough? And so what symptom burden do they have? And then when we look at decline, we actually break it down to functional decline, nutritional decline, and cognitive decline. So functional decline is, we look at the palliative performance score, which is the 50%, and that's in general. But if people have cancer, we look at that score, and if it's less than 70%, they're eligible for hospice. If they're dependent on 3 out of 6 ADLs, so actually activities of daily living. So what are those? It's ambulation, transfer, bathing, dressing, toileting, and feeding. So we look at them, and if they're dependent on 3 or more of those, then then that's one of the criteria. If they are falling more or sleeping more, so that all comes under functional decline. So nutritional decline is they're losing weight, they have dysphagia, they're not able to eat, And we also look at their serum albumin and cholesterol levels. And we say less than 2.5 for the albumin is one of the criteria we use, but that's also not always true because we look at weight loss. We look at if they've lost about 10% of their weight in the last 6 months. It's unintentional weight loss. So cognitive decline is, do they have more delirium? Are they more confused? Are they more, forgetful? Or if they're getting agitated? So we take into combination all of them, all the functional, nutritional, or cognitive decline. And if they have decline in 2 or more of these categories, then we would admit them to hospice. We also look at healthcare utilization. So the number of ER visits, the PCP visits, hospitalizations, if they're having recurrent infections like UTI or pneumonias, aspiration, and if they have refractory ascites or progressive edema. And then we take into account what is the comorbid conditions. It's pretty much everything that we see that brings the patient to the hospital, right? COPD, CHF, a stroke, ALS, MS, Parkinson's, liver disease, renal disease. And we also take into consideration if they have like rheumatoid arthritis, SLE, and MS. So the benefits of hospice are that you don't have to be referred to hospice, right? It's a self-referral. Anybody can do it, either PCP, a specialist, the hospitalist, the ER, the case manager at the hospital, the facility where they're staying at, or home health. So anybody can refer the patient to hospice. Families can too. There is no cost to the patient because it's covered at 100% by Medicare. They get a full team of people where they have nurses, physicians, therapists, hospice aides who would go help the patient shower and bathe. And they also have social workers, we have counselors, volunteers, respiratory therapists. We provide all HME, incontinence supplies, oxygen, and medication to the patients. RN would visit the patient weekly to see how they're doing and examine them at home. If they're not doing very well, we can provide what is called crisis care, where a nurse or an aide would stay with the patient and the family 24 hours a day and help them with symptom management, right? If the care becomes too much for the caregiver, then we provide respite care where the patient can go to a facility for 5 days, and which would give a break to the caregivers. And we also have an inpatient unit where if the symptoms are not being managed where the patient is, then we can bring them to the inpatient unit and manage the symptoms over there. So hospice can take care of a lot of things for patients. We can take care of their ascites. We can provide paracentesis, thoracentesis. We can provide oxygen to the patients. We can provide a vent at home. We provide tube feedings. We do IV cardiac medications like inotrope therapy. We do hydration, antibiotics. We can do wound care for the patients. We can provide, occupational therapist, speech therapy, or even physiotherapy for these patients. All of them are with the goal of keeping the patient comfortable and managing their care at home. It is not about providing physiotherapy so we can provide rehab for this patient and they can get better and they can move on to other things. So what are the different levels of care that hospice provides? Routine home care is like at the basic level, which is the most common one. And this is providing care where the patient resides. This can be at home at a facility. It can be in an inpatient unit. It can be in a memory care unit, or wherever the patient lives, pretty much that's where we would provide the care. The next level up is the continuous home care, is wherever the patient is, if they have unmanaged symptoms, then we can provide care in the patient's home or place of residence. It's a minimum of 8 hours of care a day, and more than half of it is provided by either a nurse or an LVN, which is in addition to the care or support that the patient's families or caregivers provide. The next level beyond that is inpatient respite care. So for example, if you have a patient with dementia and the families just want a break for a few days, or if the families have an event to attend and they're the primary caregivers for the patient, then what we do is we provide respite care where the patient is moved into a facility for 5 days, because that's the maximum allowed days. And so they go into a facility for 5 days and care is provided, to the patient while the families go and attend their event or get a break or do what they need to do in those 5 days. And the final stage is when all above doesn't work and the patient needs, more care, where they have respiratory distress, intractable nausea, vomiting, or their pain is unmanaged at home, then we can bring them to an inpatient unit where we take care of them. I've included a whole list of resources that provides information on palliative and hospice care. And that is the
So,
do you guys
yeah,
have any questions?
that's exactly what we're coming to. Like I had actually, thank you very much, Arthi. That was a very, very enlightening talk. I mean, this is something which what we have strived for all year. I mean, something which every specialty will get a gain from. So it's not specialty specific. And this is such a, I mean, I just did not know that you can refer patients to hospice from ER. That's another thing. I mean, I had no idea. I had no idea that hospice was self-referral. You can go to hospice. And I believe many of us, I would agree, I would ask other people to chime in here if they want to, but none of us kind of knew that this angle of hospice. So thank you very much so let me just ask you a few questions which we have
Of
here.
course.
So this is from, let me see how I can make this view bigger. Okay. Give me 1 second. I'm going to make this thing a little. So Kamala asked, I deal with many Hispanic and Asian patients and their families who are not generally responsive or open to DNR and hospice care. And case in point, there was a 101-year-old Asian female intubated and family wanted full code and wanted us to do tracheostomy. Patient has a small neck, high risk. As long as family who makes decisions for full code and push for futile care that has no financial responsibility, this makes the end of life costly and eventually ends up dying. And government needs to place financial burdens on families who resist DNR. I know that this has been something which I also would echo. I've had patients who absolutely, the guy is on vent and there is no reason for the guy, but because the son doesn't have to pay for it, Medicare pays for it, this is, doc, you do everything. But if there is something you can put, either a committee which decides who can go on DNR, then there'll be outcries like we had during Trump's time that, hey, hospital is deciding what to do with my grandma. And that's another outcry we had during President Trump's time also. And then the other point is that if there is some kind of financial thing laid on the family, said that, okay, fine, we'll continue care, but 20% you have to pay. Those things might deter those things. But go ahead, you are the expert.
So that's why I go back to my graph, where it's important to have some of these conversations when the patient can still make decisions, right? Pretty early on the care. And unfortunately, as we all know, in our Indian community or Hispanic community, we don't like to talk about these things to our family members. In fact, a lot of them, like us, the family decides for the patient, and the patients don't actually make that decision for themselves. I think in cases like this, it would be a good idea to bring it in your ethics committee to talk about, along with the palliative care team in the hospital, to talk about, what futile care. I'm going to say something along those lines, which I learned during my fellowship and I find very useful. Whenever I have DNR conversations with families and families resist, then I actually set a goal for these families. I would tell them that, sorry, I can't hear you if you're talking. I actually set a goal for them. I used to set parameters. I used to say, okay, your patient or your family member is on the ventilator. And these are all the things that we're monitoring for the patient, whether it's labs, whether it's vent settings, or whatever they need. And then I give them parameters. I'm going to say in 24 hours, we're going to see how your family member is doing. And we're looking for these parameters, either improvement in lab function, or if there's decrease in vent settings, or less support from the ventilator, or there's no fever, whatever the criteria you guys want to use, right? So you use that and set an expectations for the family. And by doing that, you actually agree, or you agree on a shared decision making, right? You decide that the patient is not doing well. You decide that there are some certain parameters you're going to look for. And if that patient reaches those parameters, then we'll proceed to the next step. But if they don't, then we have to sit back and have another conversation on whether this is really, is this really feasible or not? And that time frame can be anything depending on families. When we worked during my fellowship, we saw so many patients who had COVID, who had multiple comorbidities, who were on ventilators, and the families just did not want to stop. I know one family drove 3 hours each way every day to come visit their dad, and none of them wanted to do it, right? And so we finally sat them all down. We got everyone down together. We had one of our residents who spoke Spanish, who was excellent at this, right? And that really helped, because having somebody, not a translator, but a medical professional talking to them in their language helped. And so we gave them parameters. We said, this is what we're looking for. And unfortunately, every day we give them similar parameters, or we have these expectations that the patients improve, and we're not seeing that. So why don't we come back in 24 hours to see if these things were met or not? And if the patient does not improve, then we know that no matter what we're doing, there is no improvement in the patient's baseline. Once we started doing that, families became more receptive. But obviously, it's important to start talking to them much earlier on during the disease illness. So the day of admission, you give them 24 hours, and then at that point, you actually start having realistic conversations with the family. These are all the things that we're seeing, which is not good. These are the treatment options that we're going to try. And this is what we're monitoring for. And in 24 or 48 hours, we're going to come back and talk to you and see if that we were able to reach those goals or not. And I found that by doing that, it felt that the families felt they had a lot more control, and they were more willing to listen to us in 48 hours, because we were meeting them where they were at.
Awesome. I think Dr. Rambatla also, follows up with that question, saying that the reason perhaps is because the family, the son, daughters have not spent too much time with their parents, and suddenly start feeling guilty. And hospital risk management also yields up to the request, because they don't want bad scores. Hospital bad scores, so they don't want conflict. So all these things kind of is a snowballing effect, and that actually makes people decisions like this so difficult. And people like you, if you can come up with some guidelines, some government or if you have got a hospice society guidelines, like we follow guidelines for AUA and tell them that, or these are the guidelines we're following. If there are some guidelines which are printed guidelines, then the hospital will have some more teeth to actually step down and say, no, this is enough. Dr. Prabhakar Sharma, he asked, what does palliative care services offer to patients on dialysis beyond routine supportive care?
So it just depends on the patient and their home circumstances and what kind of symptom burden they have, right? And we don't just support the patients, we would also support the family members, right? And so you're right about more than symptom management and helping them with the initial stages of dialysis, probably not much except to be, hey, we're here, we're going to support you. But when they reach the stage where the dialysis is no longer working, or they're not tolerating dialysis anymore, or they are on dialysis for an hour and they drop their pressures and they're not really doing very well, that's when palliative care can jump in and actually help with goals of care conversation, deciding what is important to the family and the patient and the families, and how they want to direct the care, right? So patients can then decide what they want to do going forward. And again, it's all about setting parameters for the patients and their families, right? And helping them, like pretty much like holding their hands and guiding them through their disease process. And we can be your voice in a way, right? Because if you come to us and say, hey, we're worried about this isn't working, and would you be able to have a conversation with the patients and their family and tell them, or to set goals, right? Like you said, we need to have, something that can make the patients and their families accountable, right? And that's something that palliative care can help you with.
Great. So a lot of people have commented and congratulated you for an excellent talk, and you'll read that in the chat box afterwards. And there is no doubt about it. Some people have asked where they can get your slides. I think Vijaya posts this in the AAPI website, and I think you can go to the AAPI website and go to the CME link and see those slides. And also they asked for your contact. So if you don't mind posting your email address, at least the official email address, on this chat box later on after you finish your question and answer, that would be very helpful for people.
Of course.
Dr. Mata Arun asks, are third-party vendors who counsel patients and relatives, these are third-party vendors who counsel patients and relatives about appropriate choice of care for terminal illnesses, and that has been an issue. The third-party vendors sometimes counsel patients that, hey, you can do this. What do you think of that?
So I'm apprehensive about that because one, we don't know how much experience this third party has with that particular disease. I don't know if they're medically trained or not. I don't know where they're getting that information and what are they basing their advice on. I don't have information on any of that. So I would be apprehensive about that. But also if the families come to you and say those things, it's more about exploring what is important to them, right? It's like, so if supposing a family member comes and says, hey, we've advised to stop dialysis. So instead of reacting to that and saying, why would you want to stop dialysis? I think that's the craziest idea. You should just go to them and say, what makes you say that? And why did you say that? Who advised you? And what kind of advice did you get? And so once you start digging a little bit to understand where they're coming from, then that would be a little bit more helpful in redirecting the patients and their families to what's really important and what is the correct management at that given stage.
Awesome. Thank you so much. A comment from Dr. Vance, Chetna Vance, about can you comment on room and board in SNF, and does Medicare cover that?
So unfortunately, not always. The patient, so I think Dr. Veera can also jump in at this point, but I think for boarding and lodging, it has to be Medicaid that covers it. It's not covered by Medicare. And that's sometimes a problem, but we have people who can help you with that. There are patients whose families have put all of the patient's property in a trust so that then they become eligible for Medicaid. But it's a very stringent criteria, and we are also struggling with that a little bit.
Okay, so and then Dr. Mahadeva Hunasikarti, he says that, made a very great comment on this. You don't treat viral illnesses with antibiotics. Similarly, physicians should not offer an unreasonable therapy, example, chronic ventilator, at the end of your life. Your comments.
So yes, again, we are not there to impose what we think or don't think on patients and their families, right? They have to make their decisions. All we do is offer options to them and tell them pros and cons of what's important. But you can take it to the next step and said, like, for example, I have a patient who started having patient on hospice who started having slurred speech. And so at that point in time, they called me and said this patient has slurred speech. They want to go into the hospital for a stroke workup. They want to have a CT and MRI and confirm all this. So, and this patient was already 90 plus, had a very poor quality of life, was bedbound, wasn't able to communicate her needs, but she was able to say a few sentences a day. And that's how they found out. So I actually, got onto the phone and spoke to the son, and I was like, what are some things that you are expecting that, right? Yes, we can do a scan or an MRI and we can find out she had a stroke. but what is the next step? Are you willing to put her through any therapy goals? And is that going to really benefit her? Is it going to improve her quality of life? So we actually had a long conversation. And after that, they just said, no, we don't want to go to the hospital. We'll just keep her comfortable. And believe it or not, 3 months later or 2 months later, the patient is still here, still having a little bit of slurred speech, but still status quo, and is doing pretty okay, actually.
Awesome, awesome story. Dr. Arun follows up with that third-party people who he was talking about is Vital Decisions. And Dr. Raman says that all the entire leadership in that is non-medical. So obviously those are people who benefit from the patients being on end-of-life care without anything. So I don't know whether the meeting recording is going to be available, Dr. Patel. That I need to find out from Vijaya. I think she can post it on this chat box, whether that's a meeting. I know the recording is there, but I think she can just put a little comment on that. But all meetings are recorded, yes, and hopefully we should have that available on the website. The last question we have before we move to our next speaker, again, Dr. Rambatla is asking, can patients have TPN while under care of hospice? Because of this reason, one of our patients' family opted palliative care at home. So can you answer that? Can they get TPN?
Yeah, we actually do TPN at home, but for a limited period of time, right? And we can do Clinimex at home or Cabivan as well. So what we tell patients and family is, like, we talk to them about why they want to continue that and whether it's beneficial or not, right? For example, I had a patient who said, hey, I want to go home because my grandson is graduating in 3 weeks and I want to be alive for that graduation. So to meet the patient's goals, yes, we can do it. And we can do it up to that point. So what we say is, yes, we'll help you, we'll give you TPN, we'll give you nutrition up to that point. But then at that point, we're going to sit back and have this conversation and then see if it's beneficial to you or not. And so if the patients want to continue it after that stage and they're doing pretty okay, it's okay for them to discharge from hospice and say, we no longer want hospice, and go back to regular care. It is not set in stone. People can come on hospice. If they feel they're doing better, they can leave and they can go on to have other therapies and come back as well whenever they're ready, right? So it's not like they say a death sentence, right? And it's not set in stone. It's very flexible care, and and we evaluate them at regular intervals to see if they're still hospice eligible or not. It's just it's a really flexible thing, and a lot of patients and family benefit from it. So I would say, please consider it. And if you have any questions, reach out. I'm very happy to answer those questions.
There are a few other questions in the open question and answer box. You can put the question and answers. You can type the answer there, but this is specifically like one of them is palliative care does not have to be near the end of life, can start earlier. What's the role of euthanasia in hospice? And Kervokian. Unfortunately, not all hospice provide the same care. Some hospices are better than others. What's your comment? And the last one is that there are families who keep the patients alive because they're getting their social security check. And that's one of the reasons. How can you? So those are the very, very interesting topics, interesting questions. But because of time, we'll move ahead. But you have an opportunity to answer them directly on this forum. Okay. So please do that.
Thank you.
So wonderful talk, Arthi. Not only that, it shows also your passion. I mean, you're absolutely dedicated in this thing, which is very, it's not something, it's outside the box kind of thing. When we have our kids going, we want to go to surgery, medicine, wow. But you have taken this up, and this is really, really very, very, eye-opening talk which you did. So thank you again. And before I move on to Heather, I'd ask Sagar if he has got any comments on this before I move on.
So good afternoon, everybody. It's a fantastic job, talk by Arthi. One of the challenges I want you all to think about when we talk about hospice is that many a times hospice is abused. So what you think is people use hospice just to get some kind of healthcare at home. And patients come to you, which really are not end of life, but they'll say, oh, I'm on hospice. So don't get carried away to believe that that means that they are going to die and you don't have to do anything. So go into the details of asking what the character of the hospice care is really and what the strategy is. So you need to go a little deep as clinicians to understand when they say that they are on hospice, because sometimes they are trying to get around the system. Maybe Heather and Arthi can correct me if I'm wrong, but they're trying to get around the system to get some kind of healthcare at home. And because hospice provides that, they call it hospice, but technically that's not hospice. And as Arthi said, you can get on and off hospice anytime you want. The other challenge is also is that the clarification, which I don't know whether Arthi and Heather can address those, is the difference between DNR and DNI. And this war continues to happen even today with the relatives as to what is a DNR and then the DNI, and do they want you to do CPR, but they don't want you to do CPR. So that could be another topic altogether, but that comes under the purview of end-of-life care. And hospice, palliative care are all a part of the paradigm of the end-of-life care. So I would leave these questions to everybody in the audience to ponder about, but please understand these are real challenges in American healthcare which we face, is the ring around, which I call the ring around of hospice, and the hospice used for some kind of home-based care, which is wrong, but they use hospice for some kind of home-based care, and the biggest challenges between DNR, DNI, and the whole paradigm which we fight every day. So, you know, when I work in the emergency department, Arthi is trained as a surgeon. She's trained in emergency medicine and she's trained in hospice. She's trained in India, she's trained in UK, she's trained in the US. She has seen the social system, she has seen the capitalistic system, and she's seen the hybrid system of India. So working in 3 different continents, she has that whole spectrum of looking at things. And I really feel that these challenges would warrant greater discussion, and I would leave you all in the next 1 hour to think about these, because these are real challenges faced in whenever, and as duty as clinicians, when we put somebody for DNR, what do we have to really get written in clarity? Because there is a huge difference between DNR with the DNI, whether treating sepsis is important or not in a DNR patient, and sepsis is a big paradigm today. And when hospice starts sending patients back to the hospital for further care, which Arthi alluded to in a very small section, you have to be a good director to be able to certify, but when you're in half asleep, you have to take them to the ER. So nobody wants to sit and argue with the relatives. So think about these questions as we go into our next talk. And I really congratulate Arthi and for finding time to speak at AAPI. By the way, Arthi doesn't know what AAPI was, and that's something which AAPI has to address. And I had, so that is a big thing which I would like to bring it to the leadership of AAPI, that this is the new generation, my generation, Pravidya, and I had to explain what AAPI was. So with that, I'll close it.
That was many months ago.
Okay.
But that is a very, very great plug you threw in, buddy. I really knew that. It's a very, very nice, subtle plug. Yes, we have to reach out to young physicians. That has been our goal. Unfortunately, for some reason or the other, the concept of AAPI has not trickled down. We are trying our best. In the last few years, we have made great strides, and we have had excellent CME speakers and stuff like that. But unfortunately, most of us Indian physicians who come from India, we also like to have some good food and entertainment whenever this comes in. And for some reason, that overshadows the excellent work we do in India and here also. We do a lot of charitable work. We do a lot of excellent other things which we have done in India. We gave HPV vaccination for I don't know, hundreds of women during when we went for the global summit, etc., etc. All those things are on the AAPI website. So take a little bit of time and read what else we do. Unfortunately, only people remember that this big artist had come for the convention and there was good food from this restaurant, but they don't remember the other good things which we do also. Please go to the website and please educate your fellow young physicians, young Indian physicians or Indian origin physicians to come and join AAPI. Thank you for that, and wonderful. And let me introduce our next speaker. I'm sorry we went a little bit into your time, about 7 minutes, but I'm sure people will stay around if it has to go on beyond the 2 hours. So this is, let me introduce our second speaker, Heather Wieder. She is a regional medical director at Vitas Healthcare, and her topic is, it's time to have the talk. My God, I remember my dad saying that one day. But anyway, Heather joined Vitas Healthcare in 2015 as medical director in San Antonio, Texas. She was promoted to the regional medical director in 2019 and oversees programs throughout the Midwest and South Central United States. Heather is board certified in hospice and palliative medicine, as well as family medicine. Heather currently serves as a board member of the Texas, New Mexico Hospice Organization, previously served as the board of directors for Adobe Contemplative Care for Dying in San Antonio, and is also a member of Gold Humanism Society and other professional organizations. She also serves as clinical faculty for UT Healthcare San Antonio. Each of her responsibilities helps her to fulfill her mission, which is to prevent and alleviate. Heather, without further ado, the stage is yours.
Thank you. And apparently the last word got cut off of my bio, is that my mission is to prevent and alleviate suffering. So thank you all for having me. Yes, I apologize for that. But I think Arthi and I have very similar approaches when it comes to doing what we do. One of the things I love about working in hospice and palliative is that I get to meet people where they are, right? So however they got themselves to their current situation, I don't need to lecture or judge. I just need to meet them where they are now and help them the best that I can. So let me share my screen and we'll get started. So yes, it's time to have the talk, and I'm very glad that that came through the way I intended it to. I don't have any financial relationships and won't be discussing medications today. So my objectives today are that at the end of this, that all of us on here understand the importance, the challenges, and the outcomes of advanced care planning. And we can compare and contrast advanced directives versus advanced medical orders. So I will touch a little bit on do not resuscitate, but not to the extent that I think we need to. Identify and use tools for having these conversations, and then some guidance and resources. So why is advanced care planning important? I mean, I will refer you to the previous hour where Arthi was talking, but right, the goal of advanced care planning is to align care with people's wishes and their values, especially when they're nearing the end of life. And this is especially important if people aren't able to make their own decisions. Of those who complete advanced directives or they share their preferences, if they've at least had that conversation with their family or their caregiver, then what we know is that the majority of people who make a decision about this choose for palliative care rather than life-prolonging care. And I also want to clarify, because we have, I think, different definitions of palliative within medicine. So from my perspective as a hospice and palliative physician, palliative simply means that we are addressing symptoms. We aren't trying to improve a disease. We aren't trying to cure. We aren't trying to prolong someone's life, right? It is really a quality of life symptom burden focused intervention, right? And it's patient focused, meaning we're leading with what are your wishes and goals. I'm going to contrast that with, in oncology, we often hear about palliative chemotherapy, and there are some chemotherapies, I think, that really are palliative and really improve symptoms. Most of the time, though, they are geared at alleviating some symptoms and prolonging life some, but generally they aren't as effective as your first line, second line chemos. And while they can help somewhat, they aren't going to help as much. Many of them still often have a pretty significant symptom burden. And then I would say, especially when someone nears the end of life, a lot of the interventions that we use in hospice will alleviate symptoms better than the chemotherapy, and they won't have the side effects. So I don't mean that in any, please don't take that in anything but the spirit in which it's intended, in that we have different definitions, and I think that can be very confusing for our patients. So why else is advanced care planning important? Of those, the majority of people surveyed, and we'll see this when they are polled, they say that they would be comfortable having a conversation with their physician, with their family, with their loved ones, with religious leaders. And we'll see that even though that's the case, it still doesn't happen. And then studies also show that the majority of people in the United States would prefer to die at home, but we have the opposite happening, right? So the majority would like to die at home, but the majority still end up dying in hospitals and facilities, and often while pursuing life-prolonging treatment. So what are our challenges? I think it can really be broken down into two categories, right? We have often a lack of knowledge about advanced care planning, and as well as discomfort with conversations around end of life, because they're hard things to talk about. And this affects both us as healthcare professionals and the general public. So what I want to talk about here is that lack of knowledge. I mean, there are a number of people who don't have any idea about hospice. I think that is becoming less common, but it is still there, right? And there are definitely pockets where hospice is not readily available, and palliative care is even less so. So that's one issue, and that, having conversations, having CME like this, or having representatives from a hospice or an end of life nonprofit go and speak at a church, speak at a community function, is one way that we're able to help share that this is something that is available to people to help them through their end of life journey. I think another area where we generally fall short is that even if we're aware of hospice, we don't really understand the purpose of it. And again, that's both those of us in medicine and the public. We've had discussions with a number of physicians that don't want to refer to us. because what they think we're doing is unethical. But we are the purpose of hospice, right? We prevent and alleviate suffering. We do not ever have the intention of hastening death or prolonging death. There was a question earlier about hospice and euthanasia, and I'll include physician-assisted suicide in there. I can tell you that VITAS as a company has no specific stance about physician-assisted suicide, but we also don't consider that to be within the realm of hospice because we're specifically designed not to hasten death. So if somebody has physician-assisted suicide plans, that doesn't mean that we cannot support them through their end-of-life journey, but we're not affiliated with performing that. But what is the purpose of hospice, right? The purpose of hospice is to support patients and their loved ones during this time. So yes, it's a Medicare benefit, right? And the only one that I'm aware of that specifically has benefits for the caregivers, for the loved ones. Our social workers and our chaplains are meeting patients and supporting them, but also the families. And bereavement for at least a year is also, it's a requirement of what hospice provides, is bereavement support. So it truly is holistic in that it is designed to support patients and their families in multiple ways, like physically, emotionally, you name it, that's what we're trying to support. It's really hard to alleviate someone's pain, their physical pain, if they're in so much emotional pain, right? They're tied together. So that's where our social worker and our chaplain can be such a wonderful asset in helping do that. And of course, most people associate hospice with dying, right? Because our patients are terminally ill. But so I work for VITAS. So VITAS means life in Latin, right? That's the reason that they picked the name, is that we're trying, our goal is to improve that quality of life and help people truly live as much as they can in the time that they have left. And I think that purpose is lost in much of today's medicine, right? We really are, the idea of hospice really is a feel-good thing, but it's also a business, and it is, as soon as it was, designed by Medicare, right? Where we have the government involved now too, so we have rules and regulations that, of course, we must follow and we should follow, right? And I think about Sagar's comment about people trying to take advantage of, getting care at home and using hospice as kind of an easy in and out to get that to happen. And I can tell you that's never my intent. I know that's never Arthi's intent. And if someone is truly not eligible for hospice, we will collaborate with their referring physician, their primary care physician, to transition care back to someone who can manage a chronic disease state. But, and I guess the other issue I think about with lack of knowledge is lack of knowledge of procedure, right? And most people don't know that a referral to hospice can come from the patient themselves or, one of their family members. Now, to be admitted to hospice, we need to have the, physicians, that at least, the two physicians attesting that they think somebody is eligible for hospice. But a referral can come from anyone who cares about that patient. And, as far as where people are, right? So if you're in a big city, it's probably pretty easy to find a hospice. If you're somewhere rural, it's going to be harder, and especially with our staffing shortages around the country, it may be even harder then. I think probably one of the biggest challenges is, well, okay, I have my pick of hospices, but who's good? And scores will be coming out soon, like the hospice compare kind of thing, right? I mean, some are already out, but then again, that doesn't always tell the whole story. So it is a challenge. I don't have an answer for that procedure, except that being part of this organization, I think probably we all have connections somewhere, and Arthi and I would be happy to help connect with somebody and do that in a way that is not biased. I'll say it that way. So what's another challenge with advanced care planning? So it's that this discomfort around having conversations around end of life. Right? I think going through a hospice and palliative fellowship, it's helpful in understanding our medical interventions, what medications are appropriate here, what is the prognosis, what are the different things that we're looking at. But I think one of the most important takeaways from fellowship is you have a year of practicing having difficult conversations with patients and families, because they aren't easy, right? They're important, but they aren't easy. And I think a lot of us make assumptions about what somebody thinks or believes and what their family thinks or believes based on, where they come from, what their heritage is. And that definitely has an impact. But the most important part of it coming from us is asking that person what they think, what they feel, what's important to them. That's our number one thing to find out, right? And it's hard for us to ask those questions. I still sometimes, you come in and you start a conversation and it's hard, and I feel like I'm tripping over myself to start it. Once I'm in it, I'm fine. But I don't know how somebody's going to react. I don't know where they are emotionally. And I don't know who these other people are in the room, right? So that's one of those things we ask. Oftentimes we as the physicians, we carry that authority in with us to say, I'd like to ask these other people to leave the room for a moment. And generally most people will listen, right? They're like, oh, the doctor came in, I need to listen to them. Although I'm a little 5 feet tall white girl who they think I'm the social worker, so they may not listen to me, but it generally works. And just because these conversations are hard doesn't mean we shouldn't have them, right? That's the whole purpose of meeting here today with this. And looking at somebody's thoughts, somebody's culture, talking about our parents saying they don't want to be a burden, right? Well, I want my mom to be a burden when she needs me, right? And not a burden in a bad way, but I want my mom to need me. Whenever the point comes that she might need me, I want to be there to help her. And that, of course, is different based on each individual family and each culture, right? So I come from Northern and Eastern European heritage, and my grandmother was very, very stoic. I was very scared of her. I did not misbehave around my grandmother, right? And I don't know that she ever told anybody what she wanted. She you know, she soldiered through. She ended up having colon cancer, but her kids stepped up, even though she didn't share. Her kids stepped up. I think it would have been a lot easier for them if that conversation had been had before, right? Because not only is it what's important to you, but if we're able to have these conversations before you truly need them, then this lifts a burden off of your children. This lifts a burden off of your family, because instead of them wondering what your wishes are, is it okay to be intubated? Is it okay to have tube feeds? If we've already had that conversation, then that decision doesn't rest on their shoulders. You've already made it for them. So many things. I mean, I think we could have a whole nother lecture on how someone's culture and their family, you know, inform their decisions around end of life. But I think my biggest takeaway from this is that whatever room we're going into, whatever person we're going to talk to, we can't assume that we already know what their decisions would be. So some challenges, so some numbers to support what I've just been talking about. So we just don't initiate conversations around end of life care, right? You can see from these couple different studies in 2017, only 11% of the public had had a conversation about end of life care with their healthcare provider. And in a study from this year, more than 71% had never been had this conversation with their healthcare provider. So that's an improvement, right? And we can see that it's more people have had that conversation once they are 65 or older, but it's still lacking, right? That leaves the vast majority of us not having had that conversation. And then in 2017, this study here showed that about a third of people in the United States had completed some sort of advance directive or healthcare power of attorney. And this is clearly a number of people doing these without having that conversation with their physician, but having that conversation with their loved ones. The sicker people are, the more likely they are to have completed documents, and the older they are, the more likely they are to have completed documents. And the goal here is not the document, right? It is very helpful to have that document. The more important part is the discussion, that conversation that leads to the document. So what happens when we have advanced care planning conversations, goals of care discussions? So I'm showing you a few studies here. The studies overall they're mixed data. We have a lot of questionable quality studies around advanced care planning. So what we need is good quality studies to happen so that we can really evaluate the effectiveness of this. So this study is, this is one of the our foundational studies, but you can see that if somebody has had, so the yeses mean, yes, they've had advanced care planning discussion. I'm sorry, I flipped that around. If someone has a living will, if someone has a durable power of attorney for healthcare, we are seeing that the likelihood of dying in a hospital is, we have the odds ratio of 0.72, right? So that's a pretty significant change. If I have a living will, if I've had this conversation, I'm less likely to die in a hospital I am almost half as likely to get all care possible, right? So ICU, intubated, on pressors, etc. I'm more likely to have limited care, and this is limited care, right, which is appropriate because someone is, is near the end of life. Not limited care as in we're cutting you off, limited care as in it's not helpful, it's futile care. And also having these conversations in these documents, twice as likely to have comfort care. So those were for the DPOA, and we can see they are very similar for having a living will, if not and even better with the living will. So some more outcomes. This is another one of our foundational studies. Through the years, there have been concerns. People have voiced that they thought that if we talked with patients about the fact that they were terminally ill, that they had advanced disease, that we were going to make them depressed and anxious. So the studies have shown that no increase in depression, nervousness, sadness, those are unchanged. It's not making people depressed or anxious, but they're twice as likely to accept appropriately that they have an advanced diagnosis. Twice as likely to be opposed to dying in the ICU. 3 times as likely to complete a DNR. And almost twice as likely to complete some sort of power of attorney. Oops, sorry about that. So because this was in conjunction with Chicago Medical Society, I focused on Illinois regarding advanced directives and medical orders. Each state has their own, often their own paperwork and their own laws surrounding this. So please remember, this is specific to Illinois, and going to your own state website, your Health and Human Services or Department of Public Safety is going to be where usually they house these. So Illinois has 4 types of advanced directives, 3 that we'll talk about here. So the healthcare power of attorney, a living will, and essentially the POLST. Now there are some people specify that advanced directives are specifically legal documents, and then they separate those from advanced medical orders. I am not going to do that here, but just be aware that sometimes people are very adamant about those. So advanced directives, the healthcare power of attorney and your living will are legal documents. So as soon as they're signed, they're valid, but they are not in effect. They're not activated until that patient is unable to make their own decisions. So as long as a person is, now this is different, as long as they're competent to make their own decisions, right, which is a legal term, they can revoke these documents either verbally or in writing. If they want them to change, if they want to amend them, they have to complete a new form. And these can be very broad or specific, right? It can be a simple form saying, if I am terminally ill, don't take me to the hospital, don't resuscitate me, don't do these things, just let me be. Or it can be very specific as to, if there is this % chance, if the doctors say there's this % chance of me surviving, then I want you to give me tube feeds and put me on a ventilator for a week. Right now, it may not always make sense to us, right? But it is what that person has written down. And that living will, that's how that living will, right? They can specify how those things are. The healthcare power of attorney is simply designating someone to make decisions for you. They're either called an agent or a surrogate usually, or a proxy in some cases. The healthcare power of attorney requires one witness. A living will, which applies only if somebody is terminally ill, requires 2 witnesses. So often people have completed both of these. So a healthcare power of attorney can make a decision anytime someone isn't able to make their own decisions. But that living will applies only if someone has an incurable illness and is considered terminally ill. So now moving to advanced directives or medical orders. So we have a number of these types of orders throughout the United States. In Illinois, it's a combined do not resuscitate, and then the practitioner orders for life-sustaining treatment. So these are medical orders. They're not legal documents. So they have to be signed by the patient or their legal representative, which I don't usually see that with a post, but often with a DNR. So they have to sign it. An authorized practitioner has to sign it, and then it also needs to be witnessed. So again, this is state dependent and may be different. So I'm in Texas, and in Texas, an out-of-hospital DNR is a standalone, and it implies, or it states it's no resuscitation. So we don't even need to specify whether that's DNR or DNI. It's outpatient, and it means that, you know, even if somebody calls EMS, if we have that DNR, then they don't resuscitate. And depending again on what state you are in, an authorized practitioner, physicians, right, we can always sign. In Illinois, as long as the resident is a second-year resident or above, they can sign an APRN or a PA. In Texas, it's physicians only. So look to your state laws for that. And then a patient with the capacity to make their own medical decisions can void or revoke a post at any time. So in this, the post can be, you know, it can be pretty in depth, talking about, you know, artificial nutrition, artificial hydration, whether they want dialysis, whether they want other life prolonging or life saving interventions. So what about our conversations? How do we address these challenges? How do we address the lack of knowledge? How do we address person and culture, right? The way we address these is through conversations like we're having now, like we can have with our patients and families. So what I'm going to talk about on the next 2 slides are 2 different mnemonics that can be helpful in guiding our conversations and reminding us of different ways we can have that, different words we can use. Because I feel like no matter how careful we are, and I don't especially like to be careful when I'm having these conversations because I want to make sure that I'm being genuine. But careful in the sense that it's very easy to offend people, and especially, I mean, unintentionally, and especially if we aren't familiar with somebody's culture, we want to be mindful of how we're using our words. So there are a number of mnemonics that can be used. Spikes was originally this, actually I think both of these were designed by oncologists. So Spikes was designed specifically for delivering bad news. So this was designed for, okay, well, we got a bad result, and you know, their cancer is much more widespread than we expected. And so this is a way to have that. But it doesn't need to be limited to delivering bad news. Right? It is helpful in almost any conversation, frankly, whether I'm at work or whether I'm at home. If I did this, I think if we all did this more, our lives would probably be easier. So when we're approaching a patient or a family, and whether they're aware of their illness or not, this can be helpful. So the first thing we want to do is, as much as we can, we want to make sure that the setting is one that's conducive to having conversation. So if we're limited by where we're practicing usually, right? Depending on the number of people, especially, well, COVID was a different story, right? But is it going to be in the patient's room? Is it going to be in a family conference room? Is it going to be in my exam room at the clinic? So we can change that only so much. But other things we can do. We can make sure that there is a box of tissues in the room. If there isn't, we can bring a little box in. As much as we can, we want to make sure that we are not standing over a patient or a family. We don't want them to feel intimidated in any way or feel like I think that they're less. We really want this to be a conversation, and as we go through this, a shared decision making, like Arthi said before. And the setting's also my own preparation for the conversation. I want to make sure that I understand what's going on with that patient before I have a discussion with them about the fact that their illness is worsening. I don't want to go in and have to ask for clarification from the family. I want them to know that I care about them, and part of that is making sure that I'm prepared. So once we have that setting in place, going into the room, introducing ourselves. After we have the setting, we have our P for perception. And perception is finding out what the patient and family understand about their situation. And I don't usually say, so what do you know? What do you understand about this? Or what do you know? Because often people may think that I'm trying to insult them. Usually the words that I will use here are something like, what if the doctors told you about your illness? Something like that, so that there's no implication that that they aren't smart enough to understand what's going on. And I can give you different phrases, and we can talk about different phrases, but we each find those that work for us and for the patients that we are interacting with. So we want to hear from them. And as hard as it is to sit and listen, this is a great time to sit and listen. If we invest 5 minutes in letting someone air their grievances, their concerns, letting them talk for that often sets the tone for the rest of however many conversations we're going to have, however long we're going to know that patient. The fact that we sat and listened to them without interrupting often really changes the way people feel about their care. And once they've shared their perception, we're going to have an invitation. And that invitation is, I'm inviting, right? I'm asking you to invite me to share what I know. So I'm asking permission. Is it okay if I share with you what I understand about the situation, right? And in asking that permission, I then have to honor their answer. So very rarely will somebody ever say no, right? If they say no, we can try to recover a little bit, but that's a really short conversation. Some want to know everything. Some people only want to know limited information. Some people want to defer to their loved ones, right? And especially in when we're looking at different cultures. Somebody mentioned earlier working with Hispanic families, and I'm in San Antonio, and having a family meeting. Determining who the decision maker can be challenging sometimes, because the person who's talking may not be the decision maker. And I'm going to generalize, right? Even though it's different amongst different families, but more often than not, it would be a daughter speaking, but it would be the eldest son who was nodding or shaking his head no. So I really had to learn to, who I was really talking to in that meeting. And I mean, it's, once we know who that is, that makes our job a lot easier. So so we're sharing our information, right, with our knowledge. We're sharing our knowledge. Perception, invitation, knowledge, right? This isn't just a checklist that we're going down, right? But these are all intertwined, right? So getting their perception, and then we're sharing ours, and then as their perception changes, hopefully we're coming to the same, the same view of what's going on. And it's really important to recognize that through all of this, right, it's a difficult conversation for us. How much more difficult is it for our patients and families? That we allow that emotion, that we recognize the emotion, and we respond with empathy. Not sympathy, but empathy, right? Empathy is, I recognize your emotion. It's valid. I will support you through it. And there may be some of, I feel this with you, right? Sympathy is just feeling sorry for somebody in this context. And our patients and families don't need someone to feel sorry for them. They need someone to help support them. So as we're going through all of these, it can be quick, it can be long. It just depends on the situation. Regardless of the length, we're going to end with a summary. We're going to summarize the conversation we had, because I may think we're all on the same page. But if we've missed something somewhere, I want to make sure that we recognize that before we've left the room. I can't tell you how many patients come to hospice. They come onto service, and then a family member's upset. And they said, well, you told me that somebody was going to be here 24/7 until she died. And I'm going, I know my admission nurse did not say that. I mean, I know that she didn't. But that family member, maybe somebody from the hospital, just gave them wrong information. Maybe someone in the hospital doesn't understand. And that family member, they don't know who told them, but they heard it, right? So even if that admission nurse says continuous care can be up to 24 hours of care in a day, right? They're not going to hear that. They're going to hear that's 24 hours a day. So I think a lot of times we say, well, they have unrealistic expectations, or I can't believe they're saying this. Well, they aren't necessarily lying to us. There are those who will, right? But they're struggling through this. So they might not be hearing everything that is said exactly as it is said. And I know I was trying to get through faster, but I didn't do a good job of it. And then remap is another mnemonic to help with conversations. It's similar to spikes, but not exactly. And I think the way I kind of do this is spikes is my base. That's what I started, it's what I learned with. And then I kind of add some of these elements from remap into them. So the R is for reframe. So I use this in my knowledge section, right? So I get their perception. And when I'm sharing my knowledge, it may be a reframing of, well, this is where we were a month ago. This is where you were a month ago. But now that you're here in the hospital, things have changed. And, what this means, or if Arthi's talking about, we're going to try this for 24 hours, right? And if someone didn't respond the way that we hoped, we're going to reframe this in that context, right? So things have changed. This is why we think the plan needs to change. We expect emotion and respond with empathy. And mapping out what's important to the patient, right? What are their wishes? What are their values? And that is pulled out throughout that conversation. And they're maybe telling that to us without even realizing it, or it may be a direct question to that patient. Now that we understand how sick you are, tell me what's important to you in the time that you have left. It's a really direct request, but it also helps that person understand that you care about them and you care about them enough to be honest. So one of my phrases that I will use is, once I've known someone, I'll say, you may not like what I have to say, but I will never lie to you. And that it separates it somewhat. I am the deliverer of bad news. I don't want to be, but I want you to know what's going on. And then aligning, right? So what's important to the patient, and then in the context of their values, and then finishing with a plan or a summary, right? Of, we are doing this together. And this may not be what we wanted, but we are going to, I'm not going to say make the best of it to a patient or a family member. In the back of my head, this isn't where anybody wants to be, but we're going to make, we want this, what you have, to be quality. And then some resources as well. So if we need to share this or post it somewhere, I think Arthi and I have some duplicates. UCSF has a monthly education hour specifically for hospice and palliative. That is, it's not limited just to fellows or anything, but it's an open education forum.
Thank you so much, Heather. It was wonderful talk. It's very, very informative, and I'm sure everyone in the panel really liked it. We have got as many people who were here at the beginning still enjoying the conference and enjoying your talk. I've got a few questions. Thank you, Dr. Arun, for your encouraging words. And what he also advised, that hospitalists should actually attend these CME programs, because this is the first. I mean, usually as specialists, we may not get to see or make this hospice recommendations as much as hospitalists or maybe oncologists get to make. So so hospital at home, palliative care at home versus hospital at home. So those are the choices which Dr. Arun has given. The question we have from Dr. Vaivagala is, palliative care need not be those for end of life, and that's what they're briefly asked in the previous session also. Can you answer that, Heather?
So yes, ideally, palliative care is introduced when someone is diagnosed with a possible life-changing diagnosis. We are not there yet in the United States, though. So depending where you are, you may have robust palliative care to no palliative care. So in our ideal medical care, you get diagnosed with diabetes and hypertension, right? Okay, that's when you start your relationship with palliative care. I don't know that we'll ever be there we're getting better. Different states are supporting palliative care more. I don't know that we're going to have anything this year from the federal government, but we'll see.
Great. We've got a couple of more questions here. Again, a lot of compliments on your talk, Heather, which I did not expect anything else. Dr. Kuchipudi asks that if a primary treating physician feels that it's a futile care and supported and seconded by another physician, we should have the power to withdraw support in spite of the patient's request. Do you think what do you think about that?
So yes, we should. It's so complicated. I think, when I've seen things like that, when I see futility, rarely do I see a hospital support their physicians in doing that. Sometimes you do, but I think the optics are so worrisome that a hospital would rather continue whatever that care is than allow physicians to not do it. That being said, just because somebody wants specific care does not mean that I have to break my own code of ethics to provide it.
That's very true. That's something which we as specialists, I'll give you a little analogy or example. I see 80-year-old guys who come to me with a little elevated PSA. And I actually go back to guidelines, which I'm talking about, where I can tell the patient, look, these are the guidelines, and I'm following the guidelines so that you keep yourself out of trouble. But I've had a lot of primary care physicians who get a PSA, though we tell them not to get any PSA after 70 years old. We get PSAs, and the patient is actually sent to us at 80-year-old saying that, hey, doctor will do a biopsy on you, and I have a tough time explaining to them that I cannot. So similarly, I'm coming back to the same thing, which I had told Arthi. If we have some guidelines in hospice care, just like we have guidelines in different specialties, I think that will make the job of the physician a little bit easier.
Yeah, I agree. I think to answer a little bit of that, we rely often on your guidelines as well. So knowing, I focus on cardiology in VITAS, and every year I'm reviewing, the new cardiology guidelines and what they're saying. And they always have this great part about palliative care in there. Not enough hospice for me, but I might be biased. But at some point you have to make that decision as to whether that intervention is beneficial or harmful. And we look at the guidelines from, the pulmonology, from all these different specialties. And I would say our guidelines are, for the most part, our hospice eligibility guidelines. But I would love to talk to you more about that.
Awesome. A lot of compliments again. And Dr. Kuchipudi also follows up with another question. So what happens, and this, I'm sure this is something which you may have encountered in your hospice practice. A patient actually signs an advance directive saying that he does not want to be resuscitated. Now, he also signs a power of attorney, obviously, and then when he is incapacitated, the family says, no, we now want everything to be done for him. So how do you deal with that?
Very carefully. So none of these answers are an easy black or white answer. I want that to be, no, this is what the patient said. If someone is in hospice, say somebody's in hospice and the family is saying, nope, we're going to resuscitate them, we can't stop them, but we don't participate in it. If somebody's in a hospital, again, I think almost most hospital systems are going to listen to what that healthcare power of attorney has, right? That is a legal document. And if they are acting as the surrogate, then that, that is also binding. Frankly, I don't know which one supersedes the other. And now I have a question I have to go look up.
Yeah, that's a legal question, I guess, here, where you don't want to get into trouble with legalities and stuff. Thank you. We've got another question from Dr. Arun saying that chemotherapy and cancer treatment, he feels that in palliative care, you can get chemotherapy or cancer treatment, but hospice, you cannot. Is that correct?
In general, that's correct. Yeah. So I've approved gemcitabine twice as for patients with pancreatic cancer on hospice. Other than that, it's not very, not very helpful.
Okay. Okay, we're coming to our end. We're just a little bit over time, but I promised you another 7 minutes extra. So here we go, last question, and then we'll go for the presentations of plaques. What measures are there for civilians, or clinicians, clinicians who work with primary care and hospice, and to prevent burnout, because they are now talking about end of life, hospice, and all those things. How do they prevent burnout? Is there any coping mechanisms for them?
It can be really challenging, right? And I think we've all dealt with this over this past couple of years. And it's been really hard to deal with some of this. So it can be emotionally, mentally exhausting. And I think it's, for better or for worse, it's up to each of us to work to make sure that we are separating ourselves from work sometimes. And it's hard to do. I mean, I'm in hospice because I have a passion for it, and it can be really hard to step away sometimes. But we need to do it. And I think for any of us on this call, regardless of our specialty, it's the same thing.
Yeah, I mean, Arthi commented saying that sometimes you can take the help of your hospital chaplain or whatever religious leaders you follow, because you have a tough thing. I mean, that's really a hospice must be very, very demanding to your mental health and mental stress. We'll really appreciate what you do, and would love to have those guidelines which I spoke about. Maybe you and Arthi should start working on that and get some guidelines of hospice done. So so thank you very much, both of you, for excellent talk. Sagar, any last comments before we go to Anupama? Sagar, he's an ER physician, and I think he must be working today, and so he must have been called in. So again, thank you very much for your excellent talks. Before I announce the next month's agenda, I'm going to ask Anupama, our president, to come and give plaques to the speakers and welcome them to the AAPI Distinguished Speakers Club.
Thank you, Amit, and thank you, Dr. Veeder, and thank you, Dr. Bhaskaran. Excellent talks. I missed a bit of your half-an-hour talk because I came on a break, went back to my case, finished it. So being on call, I work at Children's Hospital of San Antonio. So I'm from San Antonio. So it's so nice to see both of you from Texas and San Antonio. So it's very nice. Hope we meet up in the conference, which is coming up in San Antonio next month.
Conference, by the way, Arthi.
Yeah.
Yes.
Yeah, I'd love to meet both of you, and maybe Vitas can do some kind of sponsorship probably. Every year, whenever we do our charitable gala, we have Vitas supporting us actually. So I want to check if we got any sponsorship from the company. But it's nice to meet both of you, and good to hear. The topic is very, we come across this. We have been
giving some guidelines to India as well, because this specialty is not yet there in India. We're trying to bring some post-graduation courses back in India on this specialty, which is like something everybody should have some knowledge. And as Dr. Arun said, yes, hospitalists should know these details. And even in anesthesia, when I get a patient for a procedure, you know, they are under the DNR and we are kind of confused, like, what do I do if something goes wrong in the middle of the surgery or something, even though there are some palliative procedures we do. So we get across these type of questions. So it's very nice to learn some of these, what to do, not to do things in this patients. And let me ask my manager, Vijaya Kodali, she will display our recognition plaques. And Dr. Arthi Bhaskaran, thank you so much for the wonderful talk today and for your contributions in the field of hospice and palliative medicine. And we welcome you as a member of AAPI Distinguished Speakers Club. And Dr. Heather Wieder, let me open the plaque.
Yeah, I'm opening, 1 second.
We mail the plaques actually home. You will get them in the mail as well, but we just like to acknowledge our gratitude to both all the speakers. This is what we have been doing for more than a year. And Dr. Wieder, thank you so much for your contributions in the field of hospice and palliative medicine. And we welcome you as a member of our AAPI Distinguished Speakers Club. And I would love to meet you in San Antonio next month. And I have an announcement to make. So we are getting close to the convention. Our time is taken for the convention, but we do have one more CME, which Amit will announce next month, June 12th. And thanks for all our audience today, you know, all the AAPI members who attended this CME on a weekend. And Amit, go ahead. Please do announce what our next topic will be next month. You're muted. Can you unmute? Unmute yourself.
Yes,
Yeah.
yes. Sorry. Yeah, thank you so much. And it's been a great 12 months. We started actually in July last year. And we actually, except from January, when we were in Global Summit, that's the only month we missed, we did our CMEs usually on the second Saturday of each month. And like I said, we kept it outside specialty specific, like today, like the last time and the time before. And so next month, though we have the convention coming up, Anupama said that, hey, let's go ahead and do one last one. So it'll be again second Saturday of next month, specifically I would say June 11th, again 12 noon. And we have got a couple of topics which we are actually struggling with which one to do. And so it will be again something similar to this, something outside the box, something outside the specialty, something which everybody should know about, and it's not specialty specific. So me and Sagar are in discussion with a couple of options, and we will certainly not disappoint you. So hopefully we'll see you back next for second Saturday of next month. And please attend the convention. It'll be awesome. And like she said, 25 CME lectures and a lot of other things going on. So your support in the convention means a lot, because that's how our society will grow and will become a dominant force, or in healthcare policy making, and have a seat on the table for WHO policies, United States task force, and everything else. That we need numbers to prove it to them. So thank you again. Goodbye.
Thank you so much, and
Bye.
thanks to all. Bye.
Thank
Bye.
you.